especially in PCS. All right, how's everybody doing today? Super pumped? Okay. So, my understanding is that you guys went through some functional neuroanatomy today.
You guys talk.
What's that?
So you guys talk.
Yeah, we talk. Now, you know why we talk? Because students always say, oh, I've never heard that before. They're like, oh yeah? Let's find out. So today, the focus will be on anatomy, okay? And I told you guys I'm not an anatomist, right? This is not A&P. But at the same time, it is important to be on the same level playing field when it comes to talking about imaging. Okay, so I relate the anatomy specifically to the imaging because you have to know your anatomy to be able to identify structures on x-rays, correct? Make sense? So it's important for us all to be on the same page as we move forward in our journey to becoming astute clinicians in terms of musculoskeletal evaluation, right? So that's the basis for today's lecture, okay? The other thing to consider excuse me, is that when we start talking about spine conditions, right, so spine pathology, we are going to start talking about motor, sensation, and reflexes in relation to orthopedics as well, right? Everybody get that? So I came up with a little chart, and I'll show you guys here after I do this lecture, to kind of break it down for you guys. So you have a reference guide for motor, sensation, and deep tendon reflexes. Okay, because excuse me, when we get to exam questions, do you think I'm just going to ask you straight up what nerve innervates the patellotendon reflex? Yeah, you wish, right? So no, I will give you a scenario potentially where I give you the sensation, I give you the motor, and you have to tell me what the reflex is, or any combination of those. Make sense? So this is hopefully between myself and, I'm doing circles, between myself and Major Rogers, you guys will start to solidify these things you guys hit on, when you guys were doing what? Cleanse skills, right? And you were pretending like you knew how to do a physical exam. You guys remember those days? Yeah? Yeah, right? So what did I tell you guys? This course, hopefully, will teach you to be better. Are you going to be the best? No. Practice makes perfect, okay? When you guys get out there in phase 2 and you're practicing, reading, that's where you're going to get that proficiency. Now I'm more concerned with competency. I want you to know these exams. And then you go out there and practice them, and you're getting proficiency. Everybody understands the difference between competency and proficiency? Right? Okay. So that's my goal, right? So that's the reason this lecture exists, because we need to get on the same page, okay? So as we're going through this, and you're like, man, I just heard this. Okay, fine. But just understand, do you know it, though? You heard it, but do you know it? Can you pick it out on a patient, right? Certain landmarks? Can you identify those structures on those landmarks on an x-ray? And how do they pertain and correlate with certain pathology? Good to go? Okay? So, any concerns before we get started? I'll do a review of the previous lecture tomorrow when we do the next lecture. Okay? Today, again, is a lab. This used to be done downstairs. It doesn't make sense to do this downstairs. The AV is even worse down there. Okay? Anybody who's been down there knows, right? And we're a little more spread out here. So this is kind of better, and you can see me. Good to go? Okay? So if nobody brings up any concerns or raises their hand and brings up a question, I'm going to get started. So the plan of attack today, right, the plan of instruction, is to go through the spine anatomy as it relates to imaging. So when it says there, spine imaging. And then we'll move on to some activities, okay? Not assignments, activities that we'll go through. A couple of them, I've simplified them, and we'll do them here together, okay? A couple of them you'll do as a group, I'll delineate those when we get to that part. And then there'll be a little worksheet assignment, activity, okay, that you guys will do individually. Now, as far as all those assignments, let me go ahead and get out of the way. They're not due today, okay? What test do we have Friday? What test do I see you studying for during my lectures? You're not supposed to respond, but yes, infectious disease, okay? I get it. So I've changed the due date to midnight, even though it's supposed to be 72 hours. On Friday. If you need more time, okay, fine. But the group assignment, I urge you to get it done today because I'll give you time in class to do it today. Okay? And again, I'll go through some more specific instructions as we get there. But I just want you to take a deep breath, breathe out, and just listen for a little bit. Okay? Because I want to go through this anatomy stuff and get on to the activities. I said it right that time. And then move on to the rest of your day and studying for infectious disease. Okay? Now that I said that, it's funny, right? But do not wait to start studying for ortho until next week. We have a nice little break between our last lecture and the test, right? That's a long time to, you're like, oh, I'll just get it done then. That's a long time to forget things, okay? Repetition is key, right? So if you wait that long, maybe you won't get as many mental reps in as you might require. Okay? Good to go? All right. I am not Major Adrian Denius, but I stole his lecture shamelessly. And it's pretty decent. He's got some good pictures, so we'll start getting into it. Spine imaging. Okay, so when we talk about spine imaging as it relates to musculoskeletal radiology, here's your overview. I'm going to introduce it. I'm going to talk about cervical spine, thoracic spine, and lumbar spine. Okay? So getting right into it, and I know you heard this earlier. I looked at the lecture. All right, so you have how many cervical vertebrae? How many thoracic? How many lumbar? How many sacral? 4 to 5, right? It varies. Okay? And what's left? Coccyx, right? All right, 7, 12, 5, 5, 4 is how I remember it. 7, 12, 5, 5, 4. Okay, there can be some variation as we get more inferior or more distal. Okay, but just understand that when we talk about the anatomy of the cervical vertebrae, they differ in some aspects than the thoracic, and then obviously than the lumbar. Okay, apparently I can't stand right there because it doesn't like it. All right, so cervical spine to begin with. So when we talk about cervical spine, this is your review of bony anatomy, not neuroanatomy, bony anatomy. So that's the stuff I want you guys to focus on today in my lecture specifically. But what's another word for C1? Atlas, because that's the muscle guy that supports the cranium, right? The dome, if you will. And then what supports C1? The axis, right? So that's that atlantoaxious relationship that we talked about a little bit in rheumatoid arthritis, correct? I'm not going to stop walking that way, sorry. Freezing in my office. So as we go down the anatomy there, you see those spinous processes there? And as we move a little bit more inferior or distal, inferior is probably more appropriate on this lateral view, you notice which process is more prominent. C7, right? So that's the most prominent one. So that's what we're going to identify today in lab on each other appropriately. Okay? So spinous processes are pretty obvious there. Okay? 7 cervical. Can you see all 7 on X-ray? Depends, right? If you got a good X-ray, maybe, but on a lateral view is more appropriate the way I should be asking that question. You hopefully can. That's the whole purpose, right? But sometimes C1 specifically is obscured, and there's a specific view for that we'll talk about here in a little bit. Any questions about this anatomy here as it stands? Okay, so you have the vertebrae. What's in between the vertebrae? Vertebral discs. Okay. Good, good. Okay, now we're looking at a superior view, so from the top down, if you will. So this is the view where you really have to review the anatomy to understand, when you're looking at advanced imaging, what relevant anatomy you should be concerned about, okay? So as you look here, you see the body, which is also what? Is there a disc in between those? Yes, right? So this is not a confusion. It's just the disc has been removed, okay? Makes sense? The lamina is that posterior arch. Everybody understands that the spinous process is posterior, right? So the lamina there is a posterior structure, okay? Don't confuse that with the anterior, which is where the pedicle is, right? So if you look there and you see that pedicle, okay, right there, that's anterior, okay, and the lamina is posterior. Same thing over here, right? So the pedicle is anterior and the lamina is posterior. So when you start talking about some pathology that we're going to talk about in the next upcoming lectures, it's important to understand where these disease processes occurs, okay? So what exits through this big hole right here and right here? The what? Spinal cord, right? Okay, good. So understand that. And then what exits through these little holes on the sides here? Arteries and nerves. Okay? And that differs, right? Depending on where you're at, what level you're at, whether you're cervical, thoracic, or lumbar. Okay, so understand that. So there's a couple of things that you have to remember too, and hopefully remember from your anatomy classes, is that some things have multiple names, okay? And we'll talk about a little bit about those as we go through it. Okay? Any questions about this anatomy here? This is your chance to ask questions. Okay? Where's the facet at? Right there, right? The articular facet. So when you're talking about the articular facets there and there, a lot of times that's where the degeneration occurs, right? Is that articular? Yes. So therefore, if you have wear and tear, where does the wear and tear normally occur when it comes to intervertebral wear and tear? At the facets, okay? Makes sense? So we'll relate that when we start talking about some of the pathology, both cervical spondylosis, which is another word for what again? Degenerative disc disease is what I heard. Or another word for that is vertebral osteoarthritis, right? Okay, AKA, those are all the same thing, guys. And that's different than spondylolysis, and that's definitely different than spondylolisthesis. You guys, everybody understands that I've uploaded that slide, right? Okay, it's still there. Look at it. Okay, understand. Get those in your head before we start those lectures, please. So no questions about this cervical spine anatomy. Okay, posterior tubercle, anterior tubercle doesn't really play into their discussion when it comes to the pathology we'll be discussing, because then you start talking about neurosurgical stuff. Okay, we're not going to go down that road. Ready to go? Okay. All right, so this is what's relevant today. So now that we talked about all those different anatomical structures, how does it relate to an X-ray? Okay, so you understand on an X-ray you can't see soft tissue contours, right? You can't see soft tissue structures. Can you see ligamentous structures? No. Okay. Can you see soft tissue structures in great detail though? No. Right? This is mainly for bone. This is an X-ray. So this is specifically a lateral X-ray. So is this a good X-ray or a bad X-ray? Good X-ray, of course, right? It's labeled. Right? So would I put an X-ray up here that's not good? And why do I say that? I say that because as someone over here astutely stated earlier, you want to be able to see all the vertebrae on the X-ray. Okay? And if you don't, and you're concerned about, for example, clearing your C-spine after trauma, do you think you're going to ask the rad tech to redo the X-ray?
Yeah.
100%. How many times have I shot my own x-rays? Too numerous to count. Okay? I don't even know, I've lost count. So understand that if you can't get the assessment you need when it comes to clearing the C-spine, you keep shooting until you get what you need, or you move on to another modality such as CT, correct? Sometimes if you're concerned about certain things or certain things have occurred, aka trauma, you may not be able to put the neck instantly you need to. So then you move on to getting a CT scan. Good to go? In some institutions, CT scan is the gold standard for clearing the C-spine. But can you see C1 through C7 on here?
Yes.
Yes. Now here's the thing I will tell you. When you're looking at this projection here, this view, you want to make sure you can see T1 as well, because you want to see that articulation between T1 and C7. Good to go? So you see how you can see at least the top of T1 there? Okay? I know you can't make it out, but I'm just telling you T1 will be relevant when we see some of the next imaging to find C7. Can you see the trachea on here? Yes. Right? Can you see the epiglottis on here? Yes. Do we get, you guys talk about epiglottitis yet in any courses?
Yes.
Okay, so you get a lateral view, right? And you're looking for what? Thumb sign, right? So don't forget, anything you see on this x-ray, even though you're like, oh, I'm wearing my ortho hat, you are responsible for it. Okay? Makes sense? You order the x-ray, yes, the radiologist has responsibility to interpret the x-ray, but if you can see the x-ray, you have a responsibility as well. Okay? Good to go? So make sure you get well-positioned x-rays with good projections. Okay? So what is another word for C1 that it says there? The arch of C2. Apologize. It's that odontoid dens, right? That relationship. Can you see that well here? No, you cannot. Okay? So then we go on to the AP projection here. And now the AP projection, you can see different structures, right? You can still see the spinous processes, but it's these little circles or weirdly shaped circular oval structures, correct? So that's what's projected there, these little structures there. Okay, you can still see the bodies, but now you can also see the transverse processes, right? So that's those projections laterally, right? Or these projections on the side here, right? So right there and right there, excuse me, transverse processes you can see. Can you see the pedicles? Yes. Okay, can you see the facets? Sort of. Okay, facets are better seen with an oblique view. Okay, but when you're looking at this again, how many cervical vertebrae can you see on an AP? It's 4 to 7. C4 to C7, and therefore you should be able to see the top of T1 as well. What obstructs your view? Mandible, and depending on if it's an AP or PA, also the skull, the base of the skull. Make sense? But everybody understands this is an AP. Can you shoot a PA? Do you have to? You can. Okay, so understand what the view is you're looking at. It should be marked. Is this one marked?
Yeah.
Yes. It says normal radiograph AP. Okay, so understand that. Okay, make sense? Okay. Can you see the trachea?
Yes.
Yes. So you're responsible for making sure that that doesn't look like there's any pathology involved in the trachea as well?
Yes.
Yes. Right, because this is, again, an image that you're shooting and you can see structures. You're responsible for all that, okay? So now we talk about, let's get that real quick. So now we talk about drawing lines, okay? So look at the, we talked about that AP a second ago. You see the transverse processes, this red line here that's being drawn down the transverse processes, okay? So that's how you would look at this and say, okay, is there any incongruency, any kind of deviation in that red line there? So that's a line drawn down either side of the tips or the most distal aspect of the transverse processes. So that yellow line, what is, I mean, it's labeled, right? But what are those little circular, weird shaped projections there? So, spinous processes. So that's another line too. So if you see a lateral medial or any kind of oblique deviation in that, then you know there's abnormal pathology there. Okay? Good to go? Okay. This is that odontoid view we were talking about. It's also called an open mouth view. Well, duh, the mouth is open, right? So that's where you can see that odontoid process right there. Okay? That's that projection, the odontoid process in the middle, that you're looking at to see the relationship between C1 and C2. Okay? Make sense? Yeah, look at the teeth. There's some missing, make note of it. But if you're looking at this view, especially here, right, you can see that there's a nice projection of the odontoid there, right, and over here. So if there's a fracture there, are there different classifications for those fractures? Yes, there are. There are different ramifications or the extent of the classification. There are. I won't test you on those. Just understand that you're not just looking to see if there's a fracture. You're looking to see where the fracture is. Is it at the base of the odontoid? Is it towards the mid-body? Or is it towards the more superior aspect or the tip, right? Make sense? Okay. Now we'll go back to these lines. These lines are very important. Okay, on the lateral view, these are the lines you're going to consider. Okay, there's an anterior vertebral line. There's the posterior vertebral line. Okay, there's a spinolaminar line, and then there's the posterior spinous lines. Do you think that when you look at an X-ray in your mind, you're drawing those lines? Yes. You are. That's the whole purpose of this slide, is to get you to understand where those lines are supposed to be drawn. They're pretty self-explanatory. The anterior aspect of the vertebral body, the posterior aspect of the vertebral body, the point where the spinolaminar aspect is, and then the spinous processes. Okay, so it's kind of intuitive. But if you see any deviation in these, do you think you're going to be concerned about pathology there? Mm-hmm. Yes, and then you might consider what, a CT scan, correct? Okay. You don't want to start manipulating the patient to get all kinds of weird views. Okay. So, as you can see, that X-ray on the right-hand side here, the X-ray on the right-hand side, someone has drawn those lines. Now, I'm not saying that you guys have extensive knowledge with the imaging systems, but do you think that the imaging systems that you'll find out there in the fleet, in the Air Force, in the Army, have the capability to have drawing tools where you can draw those lines? Yes. They do, right? What did you say? Or you said something weird. Or I said something weird. Or I heard something weird. But yes, the answer is yes. So that image on the right, is that an X-ray? It's a CT, right? Can you draw the lines in a CT scan as well? You can as well. Okay. So it's still a tool that you'll use to assess for any kind of change in those relationships. Okay. Do you think you're going to be doing this later on today? Yes. Okay. I'll let the suspense. All right. So the oblique view. Why do we get oblique views? What I want you guys to understand is, you're looking at it from the lateral view, you're looking at it from the AP view. Can you shoot into those joints necessarily? Remember those facet joints? Can you shoot into them and get a good view of that relationship on the lateral? No, you can't. Of course the answer is no now, right? So this is why you get an oblique view. An oblique view is used for determining certain very specific pathologies, or guess what? It's just another view. If you think you see something, and you get the oblique view, and now you see a nav view as well, then you're like, I think that's real. Does that make sense? One view is no view, right? So at a minimum, you're going to get two views in orthopedics. If you haven't heard that yet from me, you're going to hear it a lot from me, okay? One view is no view. It's what we call orthogonal views, 90-90 views. You want to look at it from 190, and then look at it from a 90 that looks at it from a different plane, if you will. Okay? Make sense? All right. So is there anything on here I'm too concerned about? I mean, you can see the spinous processes, right? You have a little bit better view of the pedicles. You have a little bit better view of that, the facets. Okay? If you look here, See how it says here, inferior articulating facets, superior articulating facets, right? So here we go again, right there and right there, okay? That basically is what I'm telling you. That's what this view is for, is to look a little bit more closer at those facets, okay? Good to go? Any questions about that so far? Trying to go slow because I talk fast. Okay? This is a normal CT scan. Do you think I'm going to give you CT scans on your test?
Yes.
No, I'm not. Okay. But do you think you might get an X-ray? Okay, cool. Good to go. So that's why I'm making sure to go through it. It's not going to be anything super detailed. If you do your exercises today and focus on them and maybe review them later on, you should be good to go. Okay? I'm not going to give you 312 slides, right, with different slices of the CT scan. You do know that a CT scan has multiple slices, right? Sometimes in the hundreds. We do know that an MRI does as well, right? Am I going to load that into Canvas? The system will crash. Okay? Nobody left? All right, so here's a normal MRI on the right, obviously, not the left. But if you look at that MRI, you told me that in the intervertebral foramen that the spinal cord runs down that, right? If you look on the right-hand side there, you see that long snake down the middle? What is that? That's the spinal cord, okay? So does it look like there's any compression of that? No. It says normal. It's labeled normal MRI. There's no compression there. That's a clean, healthy looking MRI in relationship to the spinal cord, okay? Now, when we look at this view on the MRI though, so on the left, right, so on the left-hand side here, that is a lateral x-ray. What view of this on the MRI is this? Sagittal. That's correct, right? So we're slicing somebody from left to right. Okay, look at them from the side, in or out. Make sense? Okay, good. You guys have all the answers today. All right. So this is of importance right now because this is the one thing that if you become proficient in reading spine MRIs, this is the view you're going to be looking at. What does it say on the bottom left there? Yes. So do you think we're going to discuss nerve roots in my course? I said it earlier. Okay, of course we are. Okay, so if there's compression at a certain level, it can cause you to find certain things on physical exam. Does that make sense? Okay, so the red arrow is the cervical cord, right? So that's, although AKA the spinal cord, right? So that's where the spinal cord runs through. Also known as the thecal sac, correct? Right? Also known as the dural sac. Okay? Because it is a membrane composed of dura matter that envelops the nerve tissue. We good with that? You remember that from anatomy, prereqs, all that? Okay? And then the blue arrow is the nerve root exiting. Okay? So this tells you that it's a C5, C6 disc. Okay? C5, C6. So what level is the nerve exiting out of? Is it below C5 or is it below C6? C6. Don't be fooled by that, okay? What does it say in the blue? Left C6 nerve root exits. Okay? See where it says on the blue there? So just because it's the intervertebral space, the nerve exits inferiorly. Make sense? Tricky, huh? When you go to your neurology rotation, one of you guys will get that wrong again. And then the neurologist will look at you and say, you need to review your anatomy. Don't use my name. Okay? I'm joking. But just understand. Okay? Is that true between C7 and T1? I'm going to make that out there. Someone's going to look it up and let us know. Okay? And the nerve exit underneath T1. Because that says C7, T1, right? Okay. So we'll keep moving. Okay? And the artery, sure. The artery is that white arrow. Okay? Do I care about the artery? Of course I do. If there's something wrong with it, sure. But you're not. That's not really a concern in my course, though. Okay. Who takes care of arteries? And they're on the cervical spine. Neurosurgery, not me. Okay. Good you go. All right. Cervical spine. So I will tell you that that is information you will review again when we start talking about C-spine pathology. I promise you you'll review it again. Because you're going to be like, okay, do I understand this anatomy and how it relates to the compression that's occurring? You're going to hear the word compression a lot. Okay? Was the word compression being used there? No. But it's showing you that it's a normal MRI, right? It's labeled. It says normal MRI. So if there's compression there, do you think there could be neurologic symptoms? Yes. That's what I'm talking about. Okay, so it's important to understand where those nerves exit. Okay? I already bored 2 people. Okay, thoracic spine. Thoracic spine, we'll go through it. And we don't really talk about too much thoracic pathology. But we'll review it, okay? Is the morphology of the thoracic vertebrae different? Yes, right, because it's midline, it's mid-trunk, okay? So it supports a lot of weight and it has a lot of motion, okay? So therefore, again, you would agree that those look more dense, larger than the cervical vertebrae, correct?
Yes.
Okay. So what else is relevant here that we haven't already discussed? What's relevant here is that when we start talking about the bony anatomy, again, from the superior and the lateral views there, you'll notice that, again, the structures are more robust and that the appearance of the vertebrae themselves looks different. Okay? The spinous processes, are they more pronounced? They are. Okay, so understand that as well. Otherwise, the anatomical landmarks pretty much stay the same, correct? Okay, but again, they're more robust, if you will, to support a greater amount of force through them, greater amount of weight support, if you will. Okay, makes sense? All right, so now we talk about this lateral view here. Intervertebral disc, right? The intervertebral foramen. Now that's all the same, correct? What's the one thing that's labeled on there that we start getting a sense of, okay, there's something attached that's not the transverse processes. The ribs, right? So we go way back and we go up here, right? Are there any ribs there? No. Okay, so what's the first vertebrae where we find a rib? One, right? Okay, good. And that'll be relevant today. Okay, so that's what we're showing there. So the first rib, can you also see the clavicle? Yes. Okay. And remember, this is a spine view, not a chest x-ray. So you won't be able to see the clavicle as it goes laterally and meets the acromion, correct? Okay, so again, you're just looking at the ribs themselves. Okay. Any questions about a normal radiograph of AP radiograph, of the thoracic spine? It looks good there, right? Transverse processes are not present, but you can see that if you were to draw a line along the lateral aspects of the body of the vertebrae, they're all concentric as it moves this way down. If you were to draw a line down the center of those, those processes, right? Which are called what again? Spinous processes, down the middle, that yellow line, okay, that we drew earlier. I know that was confusing, sorry. So, but you will agree that the lines all line up. So this is a normal CT scan on the right, not the left, right? So if you were to look at this and say, okay, do those look like thoracic vertebrae? I think it's good to, well enough to assume that you understand that those are thoracic vertebrae, because first of all, there's a lot of them, right? There's 12 thoracic vertebrae. How many lumbar again? 5. So you would assume that you're in the thoracic region. They're more robust in nature, so they don't look like cervical vertebrae, right? Okay, so just start kind of keying in on the difference in morphology, okay? Make sense? Am I going to give you an MRI of the thoracic spine? Finally got that right. That's right. Okay? So this is something, again, cervical and lumbar are two areas that you need to key in on when we talk about pathology, because those are the two we're going to mainly focus on, okay? We'll talk about spinal deformities, like kyphosis and scoliosis. Those are thoracic, right? Okay? They can involve lumbar as well. But when we start talking about this radiculopathy, right, myelopathies, we're mainly concerned about cervical and lumbar, okay? Any changes here as far as the anatomy or what it's called? No. But again, this is at the base, so those look even more robust in the thoracic vertebrae, okay? Especially the ones that are more superior. They do, right? Because that is a large, again, weight-bearing, load-bearing, if you will, axial weight-bearing occurs here, okay? Lumbar vertebrae, nothing really changes here. Just understand, as you work your way down, does that foramen get larger, the intervertebral foramen get larger or smaller? Depends on what level you're at, right? So you'll start to appreciate the fact that in certain areas it's very common for you to have certain pathology. And we'll talk about that as we get into the lumbar spine pathology, okay? Because you would agree that the lumbar spine makes it curves, right? It just doesn't go straight up and down. So the way I always describe it is that lordosis is like you're leaning back, right? Praying to the Lord, right? So your cervical spine has that curvature that goes, right? The curve goes forward, but the concave aspect is posterior. And then if you go into the thoracic spine, it goes the opposite. And then you work your way down to the lumbar spine, and again, you have lordosis, right? And that's all normal. Was that confusing? Yes? It was confusing? Yeah? All right. I have to go way back. Okay. Oops. So we go right here, and you see that curvature that we described there. You can see that the thoracic spine, the curve is on this aspect, and the lumbar spine, the curve is on this aspect, correct?
Yep.
And same thing with the cervical spine. It's not well defined here, but the curvature is back here, correct? So it's like it goes like this. That's what I'm talking about. So if you have paraspinal muscle spasm, do you lose that normal curvature? Yes. The answer is yes. Okay. I tell you that because you'll see radiologists comment on loss of normal lordosis as it relates to what? The lumbar spine, right? What we were talking about. So that is a key that there may be some lumbar spine. You see that curvature here? Right? It's like you're leaning back. Okay? Lord, praying to the Lord. That's why it's called lordosis. The curvature here. Okay, so that's a normal curve there. Okay? So if you lose that and you're looking at the spines going straight up and down, right? Meaning that the vertebrae are directly on top of each other, that means you've lost that curve. Was that a better explanation? Still no? Okay. Fair enough. We'll go through it some more. So normal radiograph AP of the lumbar spine. So when we talk about the lumbar spine, does that start getting into the SI joint region? Into the sacrum and the coccygeal region? Coccyx, right? Yes, it does. So then you start appreciating other things as well, okay? Is a lumbar spine AP a good view to look at the pelvis? No, it is not, correct? So it is not because you can only see part of the pelvis, okay? Is it a good enough view for the SI joint as well? No, it is not. So there are dedicated SI joint views as well, okay? There are dedicated pelvis views as well. This is only assessing the lumbar spine itself, okay? Can you see those transverse and spinous processes there as well? Yes, you can, okay? You see that arrow there that says psoas muscle? Can anybody see that on that picture? Yeah, me neither. You really can't. All right? You guys are liars. Yeah. You can? Okay, you can on yours, fine. But that's a joke. But what I'm saying is that if you get really good, you can see things, right? Or you think you see something. But is this the best view to look at the psoas muscle? No, right? So obviously, if you see something clear cut, sure. If you wanted to identify those structures, you're going to get an MRI. Okay, good. Somebody's playing along. Okay, so how many lumbar vertebrae do we have? 5. Okay, so you know you're at the level of the, what is this level right here? What is this crest? Iliac crest. So if you draw a line going across the top of the iliac crest, you're going to end up somewhere right at L4. Would you agree? Of course you do, because I'm telling you. Okay, so if you draw a line across this iliac crest here, you're going to end up at L4. And we'll identify that later. Okay? L4. So then if you're at L4 and you put your finger on that spinous process there, and you go work your way down to the next spinous process inferiorly, you're at L. And vice versa, if you work superiorly from L4, then you're at L3, correct?
Yes.
Okay, so that's a good way, anatomical landmarks again, to kind of start thinking about this stuff. Good to go? Yeah. Can anybody see the lordosis in this view? Yes, you can, right? So you see the curvature there, okay? You see the curvature there. Okay, that's called lordosis. Okay, this curvature here, lordosis. Okay, if it's straight up and down, you've lost that. Okay, that's lordosis. Are we still not clear about the lordosis versus kyphosis? Okay. So then someone's going to say, well, if you have normal kyphosis in the thoracic spine, how come we call it kyphosis when it's abnormal? Well, then yes, I do agree with you. Then we start talking about hyperkyphosis, right? So remember we talked about ankylosis spondylitis? Now you can have that kyphosis. So wouldn't it be more accurate to say hyperkyphosis? It would, okay? Don't sue the medical industry because of me. But I'm just telling you that now when you understand those normal curves, that sometimes you're talking about hyperkyphosis or loss of lordosis. And that's why I keep getting into that. If you have bamboo spine, right, do you think that if the spine calcifies, like we talked about the other day, then you may also lose that normal lordosis? You can't. In fact, you do, right? In advanced disease, you'll lose that. So does that mean that the patient, now that they don't have that articulation, like we talked about in the facets, right? Those facets, that they're more prone to fractures at lower forces? Yes, because they have less articulation, right? They have less give, if you will. Make sense? Putting it all together, right? We're putting it all together now. Okay? Normal MRI, okay? Why? Because it's labeled. Okay? Again, it's the image on the right. Okay? All right? So that's a different view. Everybody knows that there's a T1 view, a T2 view, a proton density view. He's saying no, but I agree. I don't agree with him. There is. Right? So there's different views. So just because that MRI view is there doesn't mean you can diagnose all pathology on there. I do agree that you don't know it, but I don't agree that that's not possible. Okay? That's a joke. I got you guys to loosen up finally. Took 3 classes, but all right, good. So I'm just telling you that when you look at these MRIs, this is why I don't test you on them. Because one slice is, when I talked about x-rays, one view is, one slice is nothing. Right? It's like when I was watching Monday Night Football and I had one slice of pizza. It just wasn't enough. Right? I had to have a half pie. Okay? But this view, at some point in your careers, you will go to the actual views, right? And you will start to see things. And I hope that's soon if you work in orthopedics. That's true. What I'm saying. Especially if you work in neuro, right? Because you need to understand, there's that word thecal sac again, right? And we talked about that's a dura mater, that envelops the spinal cord itself all the way down. Good to go? Okay? Also called the dural sac. Don't let those things throw you off, okay? Why don't we just call them one thing? I don't know. So putting it all together, there's that posterior arch I mentioned earlier, right? Posterior arch, so that yellow Y, or wishbone, okay? Posterior arch, okay? The bottom, the inferiormost tip, that's this one, right? Right? You put it all together, and then that red area that's labeled is a neural foramen. Neural foramen, okay? So do you think that's where the nerve exits? Yes. Okay, so if you're looking at this axial view, right, and you're looking at this side over here, is this left or right? This side right here. That's right. That is the correct answer. It is right. Because you're looking at it from the patient, slicing them from their feet up or superior. Right? Not distally, it's actually proximally. Does that make sense? Because we're at the lumbar spine, right? So if you're going upwards, that's superior, right? So that's proximally. Start thinking, yeah. Yes, ma'am.
Where you're pointing at, I was looking at.
Oh. Are you looking up now?
I am.
Okay, what do you, which one do you want me to point at?
Wherever you said was right, just make sure.
Oh, I'm sorry, this side's right.
Oh.
This side's right. Just want to make sure she was looking that time. Okay, all right. That's it, U.S. Army, okay? Down and dirty, kind of a review, hopefully, especially after today's lecture. Hopefully I'm more entertaining than Major Rogers. Please tell him I said that. But it's important to understand the anatomy because, again, when I start talking about these disease processes and these pathologies, I need to know that you guys know what I'm talking about. So if you don't, you need to stop me. Okay? Because this is your spine block. This is it. You get to pants and you're like, oh man, I just never quite got it. Yeah, text me. Okay? Don't text me in the waiting area of pants. Okay? But I'm saying, this is the kind of stuff, again, the more you hit it, the more you refresh yourself. I'll put you up right here in a second. The more you will understand it, hopefully, or at least be able to discern what the question that you're being asked is asking you. Okay? If I give you an MRI finding, it's real. If I give you a physical exam finding, it's real. Right? What I want to know is, when I give you the physical exam findings and I give you the MRI findings, do you understand how those two relate? Does that make sense? You guys ever heard the term, we don't treat MRIs, we treat people? Okay? So if somebody has something on MRI that looks like nerve compression, okay? That neural foramen is compressed. There's narrowing in there, there's compression of the nerve root, but they're not symptomatic. Are you going to treat that?
No.
Not necessarily, right? You're going to monitor for progression, right? You're going to have the patient come back and see if they improve or if they worsen, okay? You're not just going to treat everything that the radiologist writes on the report. Does that make sense? I swear to God, radiologists get paid by the word. Okay? They'll say words like possible, cannot rule out, hard to distinguish, things like that. And then they'll say something very, very clever. They'll put it on you. They'll say, recommend correlating clinically. And you're like, what the hell do I do with that? Right? You're like, he just put it on me, or she. Right? Just put it on me. So what they're saying is, if there's symptoms on exam, you have to decide, okay, is that something I need to chase down? Does that make sense? Would you agree that if there's compression up high, so it's the C-spine, you can have symptoms distally? Would you agree, though, that if you look at an MRI and you don't see any compression, any narrowing, and you look at the lumbar spine region, right, it's the lower, more distal region, and you see compression or you see narrowing, but they have symptoms that are peripheral in the upper extremities, that's confusing. Yes. Now, there are disease processes out there that happen just like that because they're not related to the spinal cord. Does that make sense? So that's why you get an MRI sometimes, is to rule out pathology as well. Make sense? Okay, let's take a break. We'll come back at 5 after.